Good evening, everyone, and welcome to tonight's webinar. My name is Adam, and I'll be your moderator. This webinar is part of our Breaking Down Barriers to Care webinar series. Our mission with this series is to shine light on areas of dentistry that are overlooked by many and increase awareness to help achieve optimal oral health care, which is a critical component to achieving good overall health. If anyone would like to view past Breaking Down Barriers webinars, I did share a link in the chat, so you can find that there. We are excited to welcome Fran Parathyras as our speaker tonight. Fran is a registered dental hygienist and will be talking about pediatric preventative dental care. If during the webinar anyone has questions, please type them into the Have a Question box and we'll get to them at the end of the webinar. And lastly, we are offering CE credit for attending tonight's webinar. If anyone is interested in earning CE, there is a CE icon in your control panel at the bottom of your screen. Click that icon, complete the short questionnaire, and then you'll receive a follow-up email within 24 hours to officially receive your credit. If anyone has any questions about CE, please don't hesitate to ask, or you can email webinars@henryschein.com. All right, let's get this show going. Fran, thank you so much for being here and participating in this series.
Thank you, Adam. I am so happy to be here, and I'm so grateful to be on the Henry Schein platform education, and grateful for the opportunity to be here as well. And I want to thank all the attendees for joining us tonight. Thank you so much. My name is Francine Parathyras. I am a registered dental hygienist, and I have been a hygienist since 1991. Went to Farmingdale State College right here on Long Island, and I still go there, believe it or not, for all of my CE, as well as through the Henry Schein education portal. Today, I'd like to talk to you a little bit about a lifetime of optimum oral health and how it begins with pediatric preventive dental care. First, I'm a mom. I have a beautiful family here. I have a son and a daughter. My daughter is Alexa. My son is Nicholas. My daughter works for Henry Schein as well in corporate brands as well as pro repair. And my son is aspiring to be a physical therapist right now in the process of trying to get into some schools. So we wish him the best of luck. Recently, we have, my daughter got engaged to Kyle, who's here in this picture as well. And we have a new little puppy called Morty. And so this is my family that I love so much and that I get up every day and do what I need to do for them. I have 3 jobs. Believe it or not, I'm working for Henry Schein, and I have been working for the company for almost 4 years, I'm sorry. I started out in the basically clinical side of the laboratory division. The laboratory division that I work for is called Zahn Dental, and because I'm a dental hygienist, they reached out to me because they needed somebody to work on that side of the business where I would be speaking to dentists, training dentists and their staff to do cosmetic dentistry by the use of 3D printed guides. So that's how I got into Henry Schein. At the same time, I'm a pediatric hygienist as well as a general practice hygienist, and I'm still practicing a couple of nights a week and Saturdays. My pediatric practice I've been with for 10 years with Dr. Dawn Felicetti, right in my hometown, Sure Smiles for Kids. And believe me, she has taught me really everything that I know about treating pediatric patients. I bring that expertise to my general practice that I've been working for, again, in my hometown of Massapequa, New York, with Dr. Sal Romeo and his staff. I work there one evening and one Saturday a week. Again, the expertise is pediatric, and that really is my passion because I do believe that you need to have good experience, great experiences there that you can bring into your adulthood to have the optimum oral health. So we have a couple of poll questions. So before we get started with the major PowerPoint, if you wouldn't mind just answering a couple of them for me, that would be really great. Basically, pediatric patients can be difficult at times. And, you know, I do have a lot of friends that are in the business as well who really are not comfortable treating pediatric patient. They just feel like it's just too difficult. Children crying bother them. It just takes a lot of time and really a lot of energy. But like I said, that's the building blocks of having really the most optimum oral health as you grow older in time. We could just take a couple of minutes and just answer this particular one. Thank you so much.
Looks like the results, oh, we just passed over the results.
Oh,
90%, that's okay. 90% were comfortable treating and 9% were not.
Okay, excellent. Well, that's great. That's very good to hear. In the general practice, you know, we're not just tooth cleaners. And I always cringe whenever I hear, oh, the girl that just cleans her teeth and takes x-rays. A lot of the times, when we feel, the patients feel that way, it's because our professionalism is lost. It's lost in the areas of, you know, being on a time schedule, rushing from room to room, falling behind. Okay, and there are two major components to really, you know, taking care of your patients the way you should be. And I'm talking about in the general practice. I want to know how many of you perform oral cancer screening and blood pressure monitoring? This is another full question. You wouldn't mind answering it. In this day and age, everyone is so set on basically appearance. How I look, they want either to get their teeth whitened, they're looking for, you know, maybe some straightening of their dentition with, let's say, reveal clear aligners. Basically come to us sometimes before going to their regular general doctor. Okay, so we might see those patients more often than they go to a regular doctor. So we might be catching something that could be life-threatening to the patient. So it's so important to perform an oral cancer screening. It's so important to take blood pressure, do the blood pressure monitoring, and really chart that and take notice to it. And if you see something that's abnormal, please refer them out, let them go to the oral surgeon to take a look, or to their regular doctor to get a blood pressure screening. And it looks like the results are in.
Yes, they are. 78% do, 21% do not.
Excellent. Okay. Awareness, so important. Knowledge is power, right? We have to keep that up. Okay, so this is really what we all get anxious about as hygienists, and we look to avoid. We really don't want to traumatize the patient, okay? We want to make it a comfortable, happy environment for them from the moment they step into the waiting room and we go out to receive them. It always upsets me so much when I walk into the waiting room and I call my patient and they start crying immediately. I mean, I don't want that to happen. So I'm always asking, why are you feeling this way? I give them a big smile. I walk over to the parents and I, you know, introduce myself. I get down on my knee and I directly speak to the patient. That's so important. It makes them feel important and it makes you less threatening. And believe me, it works. I do it every time. And over time, I do get the patients, you know, where they feel comfortable with me. And that's the most important thing. They need to feel comfortable. They need to feel not threatened at all, that this is a safe place to be and we're there to take care of them. Oops, having an issue here. There we go. This is what we strive to achieve. That smile, comfort and ease in the chair, it definitely makes me feel more comfortable as the practitioner working with the patient. It makes me feel happy when I see a child sitting in the chair that feels comfortable, that's happy to be there, that's well engaged. The parents are much more, you know, at ease as well, sitting there watching, because it's the last thing that they want is to see their child to be uncomfortable, crying, feeling threatened in the chair. None of us want that. So this is what we strive to achieve. A happy, healthy patient who's happy to be there and happy to be taken care of by us. Oh my goodness, I'm having a hard time. There we go. Okay, so our reality, no matter what we do, there is an underlying fear, always, because they don't know what's happening. They don't know what we're going to do next unless we give them the information. That's so important. That underlying fear of what are they going to do to me? Is it going to hurt? When am I getting out of here? Is the kind of feeling that every child has and every adult really has. They want to feel, they want the knowledge. So basically, that's what we're there for. We're there to explain every step of the way, to make them feel as comfortable as we possibly can, to let them know what's next, to let them feel, see, be engaged, talk to them through the whole thing. That's key as well. Keeping everybody informed, as well as the patients. And that goes for your, general practice adult patients as well. Everybody really just wants to know what's going on so that they can feel comfortable, know what's next, no guessing games, no fear of what we're going to be doing next. So the introduction to a pediatric appointment is always greet with a big smile. Always, always. Like I said, get on their level, kneel down, talk to the patient in the waiting room. Always tell them your name. Start talking to them as you're walking them back to the treatment room. How was your day today? What grade are you in? How old are you? Even though you know, get them talking. When you escort the patient back to the treatment area, if they're a small child, especially if it's the first time, you want to get them into the chair, make them feel comfortable, even if that means sitting on their parent's lap. I don't mind that at all. I know some people feel that it's you can't get the patient in the right position or whatever, but sometimes we have to improvise. And if that is what we need to do to make the patient feel comfortable, especially if it's their first time, you do whatever it takes. If you can't lean them back and you have to stand up to do your treatment, that's fine too. It's whatever makes the patient feel more comfortable so you can get them back for another visit. I always believe in getting the patient involved. Before sitting in the chair, I offer a new toothbrush. I let them choose their favorite color. We discuss what kind of toothbrushes are good for them. They love getting that little goodie bag with a little toothpaste in it and some floss. It's just introducing oral health at home so they have the proper materials that they can use at home. I also discuss at that point, show the parent what they need to do with these materials. Like I said before, I always offer the patient a ride on the chair, and I explain how the chair moves up, down, back. Don't be afraid when we lean you back. It's to make you feel more comfortable. I get their head on the headrest. I get them feeling nice and comfortable. And then we start a dialogue. Like I said, knowledge is power. We discuss everything we're going to do before we do it and during. And I really, really feel that that is what the best thing to do is. Always keep talking, keep them talking so that they feel more comfortable with you. I ask them about, school. I ask them about what their favorite subject is, what they learned today. Do they enjoy their teacher? What their favorite subject is, just to get them talking. If I see that they're in any sports attire, I ask them if they play a sport. I want to see how active they are and how healthy they are and what their, healthy practices are. We treat the entire patient, not just the mouth. And that's always key. Fluoride treatment is important. Every child should have. I believe every adult should have as well. At that point, once they sit in the chair, I always ask them what flavor they would like. Sometimes I have an array of flavors, but I always, I don't offer them like 15 flavors. It takes them forever to pick one. I'll give them a choice of like maybe 5 or 6. They like to choose their flavor. It makes them feel like they're in control. We have to give them control over something, and that's one of the things that they like. I always explain to them in their terms what a fluoride treatment is. They don't understand that type of terminology. They take vitamins. I ask them, do you take a vitamin every day for your body? And they say yes. And I say, do you know what vitamins are for? And they tell me what they think a vitamin is for. And then I explain, this is a special vitamin that's just for your teeth. We put it on every 6 months. And I explain to them that it can stop a cavity when it's just about to form and how important it is that it stay on the teeth. And sometimes it may not taste exactly like what you think it's going to if you pick cotton candy or strawberry, but just stays on for just a quick minute. And then we can, get rid of it. But it's so important. It's the most important part of the treatment. And I always explain that to them, and they're pretty receptive. Because sometimes, believe me, I taste them all. They don't taste like what, like a cotton candy would be, or a blueberry or something like that. Medical history is so important. That's something that I discuss with the patients upon sitting the child in the chair as well. I always want to know what the changes are in their health. In the past 6 months, has there been any allergies to any foods or medications, any hospitalizations or surgeries? You'd be surprised what a parent will decide is imperative or, information that we should have. So that's something that, we should always, always go over. Whether you look at that medical history, you need to verbalize that. I always like to sit and ask, has the child fallen and needed, to have a surgery, whether there's pins or screws or something, because, that could definitely impact a treatment, especially with a prophy. That goes for your general practice as well. Always ask, because 9 out of 10 times they forget to tell you. And sometimes they'll be like, oh yeah, I remember, this is what happened. And, I am allergic to sulfur. Or, you know what, I did fall and I did have a surgery like 4 months ago, and I do have a pin, in my ankle or my wrist or whatever the case may be. So it's a good idea to sit and verbalize. Don't just look at the medical history, go over it step by step with the parent or guardian or with your general practice patient. Always, always unbag instruments in front of the patient and discuss each piece. I do that in my general practice, and I do that in my pediatric practice. Patients like to know, parents like to know that our instruments are sterile and, clean and only being used on that particular patient. And the way to, stop those questions from being asked is unbagging and putting a new prophy angle, a new saliva ejector, a plastic air water syringe if you have them, or if you autoclave them. Put everything on in front of the patient, in front of the parent or guardian. It's so important that we do that. I discuss each piece as well with the patient. When I'm going to sit down and do, a examination, I'm going to show the patient the mirror and explain to them, can you see your whole face in this mirror? And they always tell me, no, of course not. And I always tell them it's that small because it's made to go in your mouth. And then I show them with a big mirror, have a little mirror, how I look around in the mouth with my mirror. Then I take my Explorer because they see it, they think it's pointy, it's going to hurt them. I show them the Explorer. I show them on their hand, of course, the side, not the tip, how I'm going to count their teeth with it. And I proceed to count their fingers, 1, 2, 3, 4. And then I go into the mouth and I start to count from there. At all times, the patient has the hand mirror and they can watch along. Again, they know exactly what's happening and they're not afraid. They know that I'm not going to hurt them with it. Radiograph assessment. That's something that, we take radiographs on the patients annually. Usually we start by the age of 4 or 5. Depending on where the 6-year molars are. Some of the sensors are a little big in my general practice, so sometimes it's not as easy to take them, but in my pediatric practice, we do have the smaller sensors, and it's really quick, and usually, I start off by putting my finger exactly where that x-ray is going to go, so that they understand where it is. I explain the sensor, how it's attached to a wire, and there's no way that that sensor can go down their throat because they're afraid they're going to swallow it. I can't tell you how many patients, how many children have asked me, can I swallow this? I'm afraid I'm going to swallow it. So we explain to them, how there's no way it can go down your throat. And they're pretty good, and we usually get the x-ray. But sometimes it takes a couple of times or a couple of visits, and that's okay. That's okay. As long as we can't obviously see in between the teeth, we need that. We need a radiograph for that. But if we do a clinical exam and we see that the patient really is taking good care and the parents are helping and, you know, everything looks okay clinically, we can try again the next time. Again, no reason to, you know, cause any type of trauma and traumatic experience. Always get them back at the next time. That's the key, wanting to get them back. Before, I spoke to you about the oral exam and how I engage the child with a large mirror and we count each teeth and we talk about the primary dentition versus the adult dentition, what a mixed dentition is. I show them on my, you know, my dentric screen of, you know, here's your primary tooth, these are how many adult teeth you have, what's a wiggly tooth, you know, when the tooth fairy is coming. I mean, they get very excited over losing teeth. So we need to make it a big deal. And if we see that one is like really loose, we have these really cute little teeth necklaces that open up that we give to them and they can take it home and wait for that tooth to come out. It's really cute. They get very excited. And, you know, it just puts a smile on your face. We also check to see if, you know, sealants are needed. Very important to seal in those pits and fissures, explain that to the parent, and that's always something we get the patient back for, you know, after the initial visit. Always check the bite, crowding, and discuss ortho. We kind of discuss ortho early on, usually by like 7 or 8 years old. We get them in for, you know, a quick check-see with the orthodontist so they can at least begin to talk to the parents about what to expect in the coming years. Most places, you know, don't charge for those visits, and it's really just, you know, for the parent to get the knowledge to know like what'll be coming up the pipe with them. And then, of course, caries assessment. Okay, we're going to go around and make sure that the patient is carie-free, or if there is any, discuss what the next steps are at that oral exam. Okay, for treatment, I always use scalers. Always hand scale every single tooth. Very, very rarely do I use the ultrasonic scalers on children. I will use an ultrasonic scaler on, you know, a child of maybe 15, 16, 17, you know, 18, definitely if, you know, I could see that there's calculus when they're in ortho treatment, but I will not use that on a small child at all. Always polish with some polishing paste. I really like the Clean polishing paste. It tastes great, actually works very well in removing staining. And fluoride treatment, we discussed that before. They pick their flavor. I usually wipe it on with my finger or a micro brush, actually. And then I go over home care instruction. Home care instruction is so important with children. And I never, ever, ever tell them what they're doing wrong first. I always look and tell them what I think they're doing right. And I get them excited about home care. Then I show them with a mirror where I felt they can do a little bit better. It's usually technique. They're usually brushing, definitely once a day, most kids, because they'll tell you the truth. When you ask them how many times a day you brush, and the parent will say, oh, morning and night, and they'll say, oh no, I just do it in the morning. I never do it at night. I'm too tired. I never do it, you know, and it's really funny. They say, you know, out of the mouth of babes, and it is true. Definitely out of the mouth of babes, they do tell you the truth. But I'll tell them, okay, you know, the technique, really, next time, let's do some big circles. We're missing, you know, maybe the top third of the tooth. And if you do it like this, you're definitely going to get that area. And I always introduce the flossing. So again, always focus on the good that they're doing and then introduce a new technique, introduce flossing, try to get them to definitely brush at night, definitely brush in the morning, and sometimes midday, whenever they have the time. My tip is talk through the whole process, especially during the fluoride treatment, because during the fluoride treatment, they tend to not like the taste of it, and it can go awry really fast. I mean, I've seen kids, you know, they can definitely, you know, try to vomit on demand, especially with the fluoride treatment. So I try to divert their attention, have them looking directly at me, and I talk to them through the whole entire time. And believe me, the minute goes by pretty fast, and before you know it, it's over. Nutritional counseling is a big one. It's a big one because, you know, we're not nutritionists. Definitely we're not. But it's a good idea to discuss nutrition with the parent and the child. I always want to know what their favorite vegetable is, what their favorite fruit is. I try to get an idea of what they're eating. Are they eating a balanced nutrition? Are they a high carb kid? So we go through their diet. And a lot of the time, you know, the parents will tell me they don't really like, you know, to eat vegetables. We talk about different vegetables that they can eat to try to broaden their horizons. You know, what kind of fruits that they like. If they don't like fruit, they like candy. You know, I try to tell them fruit's nature's candy. You got to give it a try. Try a really cold grape. Try a, you know, an apple. Try to get them to definitely broaden their palate a little bit. And I discuss the changes directly with the child. I keep them number one on my list. They're the important ones. Of course, I talk to the parent, but I'm really directing all my conversation to the child. I want them to feel important. I want them to feel like they matter. I want them to open up to me. Most children definitely love carbohydrates, whether it be crackers, pasta, bagels, bread, chips, rice, all of that. The correlation between caries in children and carbohydrates is pretty strong, okay? And, you know, we know that first stage of digestion of carbohydrates in the mouth turns to sugar. And you'll be surprised how many parents are not aware of that. So I always try to say, instead of sticking that goldfish packet in their lunchbox, maybe give them a string cheese or a yogurt or some carrot sticks. They come home, maybe try to, you know, change out that carb again with a yogurt or, you know, something different other than a carb. And if they really are that high carb and we do see, you know, a prevalence of caries, maybe get them in there, definitely with the sealants, definitely with that extra brush right after they eat a snack when they get home. So important, nutritional counseling. I can't stress it enough. And we should all be doing that with every patient, especially pediatric. Home care routine. Always ask them about their home care routine. Like I said before, how many times a day do you brush? Always tell them to brush for 2 minutes. 2 minutes seems like a very long time, or they think they're brushing for 2 minutes and they're not. I always say, you have an egg timer. Turn that egg timer over once, turn it over again, and that's your 2 minutes. Everybody has a little cell phone. Put your timer on for 2 minutes, and you'll be surprised like how long 2 minutes really is. Like I said, they think they brush for a long period of time. They really don't. So it's a good idea to definitely introduce those two techniques to them. And parents really need to help. A lot of the time, children's dexterity isn't that good. You know, it isn't that good until about like 9 or 10 years old. So they really should be in there helping their child. Be in there, let them brush themselves, and then get in there and really give them a good once over to make sure that they're taking care and they're getting all of the surfaces of the teeth. Definitely flossing once a day. I mean, I stress that especially with my general practice patients, but it starts in peds, absolutely. We ask them to rinse with a fluoride rinse once a day. And if they're not flossing, that fluoride is not getting to the areas that it needs to in between the teeth. So I always tell them there are 5 surfaces to every tooth. We go over what that is, and then we go over the home care. Home fluoride rinse, 1 time a daily with proper instruction. That means explaining to the patient that, yeah, it's great to rinse with that, but you can't eat, drink, or rinse with water for a half an hour after. You'd be surprised how many patients rinse with water after, and that's like basically doing nothing then. It's just a waste of time. So we have to remind them that it's really just like the fluoride treatment that we do in the office, just a minute amount that they can do every day, but to do it properly. Please don't eat, drink, or rinse for a half an hour. I always say a nighttime routine is the 3 Bs: brush, floss and rinse, a book, and bed. We keep this routine going, the kids will do great. Also for bedtime routine, you know, kids do say they fall asleep, they're too tired to brush at night. So what I always say is if you have that snack before bed, as soon as that snack is over, go upstairs or downstairs or wherever your bathroom is that you have your toothbrush and brush then. Don't wait for right before bed because 9 out of 10 times they are tired. I'm tired too. I mean, it's just human nature. Sometimes, you know, I fall asleep and I just stumble into my bed. I get it. But if they do it right after that snack and they make that a routine and the parents enforce that routine, you'll see we'll get a lot better results in the dental chair every 6 months. So the Academy of Pediatrics suggests that oral risk assessment should be done by 6 months of age or no later than 6 months after the first tooth erupts, and that every child should have a dental home by 12 months of age. I don't know of many people that I've spoken to that actually bring their child at 6 months of age or after the first tooth erupts. I get a lot of young parents in my general practice that say, what should I do? Should I be brushing my baby's teeth? You know, absolutely. I mean, they do have, and you could recommend them. They're like little brushes that attach to like your finger, and you can go in and massage their gingiva and brush those little tiny teeth that are erupting so they get the feeling and they get used to having something in their mouth. And you should do that even when they have no teeth as of yet. Even with a washcloth, get in there, you know, and explain to them they should wipe on the maxilla and the mandible gingiva. And, you know, as far as getting them into a dental home, really research, have your patients research and look for a pediatric dentist that they would feel comfortable with bringing their child at that age. The youngest child that I've seen in the past 10 years has been a 14-month-old child, and that was because the baby fell, and we needed to assess, you know, any kind of fractures or, you know, the baby was bleeding, and it was traumatic even for me. I mean, the poor little thing, she cried the whole time, and I just felt so bad, but we had to do what we had to do. So, like I said, the youngest I've seen is 14 months, but they'd like you to bring them there a lot sooner. Oops, having a hard time. Oh, nope. Sorry about that. 6-month recalls are imperative to keeping the child on track. No matter how difficult, waiting is worse for the child because they forget exactly what we're doing. 12 months, a year is a long time, a year and a half, way too long for a child to be out of the dental office. You want to bring them back in 6 months because even though it's difficult, even though they cried, it's more difficult probably on the parent than it is on the patient to see it. And a lot of the time, if they are crying, their mouth is open. We're able to count their teeth, be able to assess for caries, maybe polish a little bit for the first time, you know, give them a little fluoride treatment, actually get the treatment done, which is something that, you know, we all want to do. Children in orthodontic treatment, you know, I feel should be seen every 3 to 4 months. They have a very difficult time keeping those brackets clean. You know, it just keeps the gingiva in a healthy situation, and it keeps us on top of getting them to do the home care that they need to do at home to keep their teeth as healthy as they possibly can. So always say every 3 to 4 months, and we basically make those appointments in advance. Before we send a child to ortho, and once we, you know, discuss with the orthodontist what the plans are with that patient, because we definitely do that, we instill that as well with the orthodontic office to make sure that they're reminding the patient to come to us and make sure that they get a good cleaning in between. There is a child deep inside every adult, and a happy child of a dental patient becomes a happy adult as a dental patient. And I can't tell you how many times I've treated adults that have walked into my operatory and said to me, I love you, but I really, really hate what you do. And I sit there and I ask the question, what was it that made you feel this way about coming in? And they would tell me a lot of the time it was a traumatic experience as a child. So always remember that your job is to recognize that the reason why this patient is acting this way is because of a traumatic experience, and we're treating the child inside of them. So the same way that you would treat a child, of course, not in the same manner as you would treat a child, you want to treat an adult like an adult, of course. They don't want to be made to feel like they're a child. But you want to explain every step of the way what you're doing. Pay attention. Pay attention to their eyes. Pay attention to their hand motions. If something's hurting them, you're going to see something in their expression that's going to trigger to you that something's wrong. And then that's a cue for you to stop and explain. Say to them, is something that I'm doing bothering you? Can I change it? What can I do to make you feel more comfortable? So important. Your job is to recognize that. So now I'd like to open this up to any questions that you may have for me.
Awesome. Thank you so much. We've got about 15, 20 minutes left. So if anyone does have questions, feel free to add them into the chat or the have a question box. We do have a couple lined up for you, but before we get to them, I do want to remind everyone that if you are attending for CE credit, there is a CE icon located in your control panel at the bottom of your screen. Click that, fill out the short questionnaire, and then you'll receive an email within 24 hours. All right, so you mentioned something about not using an ultrasonic, and that sparked a lot of questions. So why is it that you do not use an ultrasonic scaler on a child?
I don't feel that they have the level of calculus needed for an ultrasonic scaler. I feel like I can do a better job with my hand instruments. I have more control over that. I feel like the water could be an issue for the patient when they're very, very young. And the sound of it can be a little intimidating. So if I can use my hand scalers and I can do a good job with those, I'm going to stick to that and polish instead of using an ultrasonic. Like I said, if there is calculus, if there's a tremendous amount of calculus, the child is older, of course I'm going to pull it out for sure. But with very young children, I feel like I can definitely do a better job with my hand instruments.
In your practice, do the dental sealants end up on the DH, is it dental hygienist schedule?
Yes,
yes.
they do.
Okay.
Yes, absolutely.
What about the dental assistant, or is coronal polish delegated?
I do all of the polishing. I don't rely on an assistant for really any treatment. I don't have an assistant that works with me. And that's fine. I do pretty good on my own. I've always worked that way, and I've been working since 1991. So I feel like it's okay.
Did you require any additional training in order to treat in a pediatric practice?
Actually, no. You know, I started out with Dr. Dawn, and she basically, you know, showed me all of the techniques. I mean, I've been a hygienist at that time for a long time, over 20 years. So I did have a lot of experience. And I did see a lot of kids in general as well. But she really showed me a lot of techniques and, you know, explained to me, you know, how to treat patients and basically the dialogue that we should be using and getting on their level and, you know, not being threatening at all, knowing when enough is enough as well. I mean, we really, really want to give the child a very good experience and to get them coming back and feeling comfortable with us. And you know what? So no prior or additional training.
Okay, this is my question. Just curious. Maybe you covered it, and if I did, I apologize that I missed it. But you said you try to keep your littlest patients very comfortable. You explain to them, in grave detail, like what you're doing, and especially in terms that they understand. Is there ever a time where you would want to distract them, or you go to a dental practice, they've got TVs, fish tanks, all that stuff? Is that beneficial when treating a pediatric patient, or would that actually make it more difficult?
You know what? I want them to focus on me. We don't have TVs in the office. We don't have fish tanks. The office is beautifully decorated. I mean, it's these murals on the walls, and we have a lot of like Disney characters in our office, and the kids really like seeing that kind of stuff. But when it comes down to the treatment, I really try not to distract them. I try to get them to focus on me and look in my eyes and listen to what I'm saying. And I'm very, very close to them when I'm speaking to them, and I'm on their level, and I feel that that works best for me. Other people might say, they need to distract them. Oh, look at this or look at that, or you're going to get a toy when you're done. And I really never ever do that. I feel that I try to be as honest as I possibly can with them without using terminology that would scare them, of course, but I just feel like knowledge is power, and for me, that's the best way that I can handle, a patient of that age. Get them to try to focus on me instead of other things in the office.
Is there ever a breaking point, so to speak, where if you have a pediatric patient and they're just not having it, bad day, hate the dentist, whatever, is there ever a point where you're just like, you know what, let's not do this today?
We've got, I can't say that that hasn't happened. I mean, we do see a lot of special needs patients as well. And you know what, you got to know when to stop. You have to know. And you know what, you get to that point where you see that they're getting to a point of no return, and they're getting themselves so upset that they're, starting to vomit or something like that. We try to get something done and really celebrate getting something done at the visit, so that the patient knows, like, we're not just going to give up, because honestly, the reason why they're with us is because the general, office really doesn't want to treat them, or doesn't feel that they're capable of treating them, has the knack of basically treating them. So we really have to give it our best shot. Absolutely. And I will, and the doctor, we really will give it our best shot every single time. But yeah, I mean, you don't want to create like a traumatic experience for them. And that's what this is all about. It's trying to get them to that point of where they feel safe and secure, and they know that we're there not to hurt them, but to help them. And, sometimes if we have a half an hour or a 45-minute schedule, you know what, sometimes we go over. Sometimes we take more time because it's important. And you know what, the other patients in our practice and parents in our practice understand, because at one time or another, it might have been one of their kids that we had to take extra time for. But yeah, I mean, we definitely know when it's time to stop. We celebrate what we have done, get another appointment scheduled, and explain to them next time we're going to try X, Y, and Z. And that's how we're going to go. I mean, we have special needs patients that, we come in and we just practice with, walking to the chair and sitting in the chair. And then the next time, using a toothbrush on their teeth, walking in the chair, sitting in the chair, spending time using a toothbrush. And then we get to the next stage of the game where we're going to use a mirror. Then we're going to use a mirror and an explorer. We kind of build to actually get those parents and those children to trust us, because trust is a major, major factor when treating special needs patients. So, we really try to not look at the time per se that's scheduled, but the quality of the treatment that we're going to be actually, performing.
And that is a perfect segue, because last year we did a 6-part series on treating patients with disabilities. All fantastic. Highly recommend everyone watch them if you were not with us. Again, I put that link in the chat if you want to view any of our past Breaking Down Barriers to Care webinars. All right, another great Yeah. Another great question that came in. What would you suggest when a young child absolutely does not want to open or just does not open their mouth for you to perform the exam and scaling, especially if the child starts to cry?
Well, like I said before, if they start to cry, I mean, that's my cue to get in there and be able to look around. You know, sometimes I kind of like stick my fingers in there and I try to open up. I try to feel around with my fingers, get them used to that. I mean, it's not easy. It's not easy, but I do explain to the child that they're here for a reason and we're going to do this. We're going to do this and you need to trust me. And little by little, let me just put my finger in. Let's just see. I mean, there are plenty of times I got bit too. Don't let me, you know, don't get me wrong. It's not, it hurts from time to time, but, you know, we just don't give up and we just keep talking and trying to get them to trust us. And if they cry, I'm going to go for it. Let's put it that way. But if they're adamant and they just keep their mouth closed, I mean, I'm going to try. I'm just going to try to get in there.
You mentioned parents trusting you earlier. Have you ever had to deal with a parent or guardian that, I'm not going to say was unruly, but has opposed what you've been telling the child for treatment?
You know, I have to say absolutely not. I mean, the parents have been great. They come to us for a reason. They do agree. I mean, there are parents that don't want fluoride because they feel that it's a poison. They don't like having their children brush with toothpaste because of the fluoride in the toothpaste. They think they're going to be poisoned by the fluoride. They don't want x-rays on their children. I get all of that. I get their concerns. Their concerns are valid. I never make them feel like their concerns are not valid, but I do explain to them why we need certain things, why we need radiographs, why they should be rinsing with fluoride, why they should be brushing with fluoride toothpaste. There are a lot of, you know, places that don't have fluoride in the water. They're not ingesting fluoride. They're, you know, the fluoride is invading their teeth when they drink water. So I explain to them, you know, what it would take for a child to get fluoride poisoning and how much they would have to ingest and how much toothpaste they would have to ingest. And 9 out of 10 times they'll be like, well, I didn't really realize that, and allow us to go through with the treatment. And other times they don't. And they're like, I'm sorry, but it's something that I just don't want. And I document the chart and I move on. So that's how I would handle a parent that was completely adamant. And like I said, 9 out of 10 of our parents are, you know, very appreciative of the work that we do and trust us wholeheartedly. And, you know, trust us in the fact that we are putting their child's best interests, and we take that to heart, and they do. That's why they bring them to us. But again, you know, you're going to have that one that will be adamant, and like I said, you document the chart. If you can't sway them and change their mind, and move on.
Excellent. Well, we still got questions, still got 10 minutes. Appreciate everyone submitting the questions. Great topics, conversations. If you do have questions, please do continue to submit them.
Yes.
On the topic of fluoride, at what age do you typically start fluoride treatments?
We'll start them as soon as we possibly can. Even if I have to take a little micro brush and just brush it on minutely and get it on there, as soon as we possibly can do a fluoride treatment, we will. And again, you know, they can't really fit when they're too young, so we'll take a 2x2 gauze and I'll remove as much as I possibly can that way.
Do you ever, and this is an interesting one, do you ever need to prescribe oral sedative medication to a young child if they are uncooperative?
Absolutely not. We have never done that. I can't, in the 10 years that I've been practicing, you know, in this pediatric office, we've never prescribed sedatives. The doctor does do sedation dentistry, but not without an anesthesiologist that will come in and actually oversee the anesthesia with the children.
Do you treat many pediatric patients in your general practice?
Yes, yes, I honestly do. We're a pretty big practice. Like I said, I am there part-time. I'm there half a day on a Saturday and one evening. And I can tell you, because they know what my expertise is, a lot of the time the children are scheduled with me. And I love it. It's great.
Let's see. I have worked with a dentist who has used a large wooden tongue depressor for the child to bite on as a mouth prop, and that was placed upright across the child's mouth. Does this seem acceptable, or would you advise against this? Have you ever seen this or tried it?
I've never seen it. I've never tried it. Again, if something like that works for someone, I mean, I'm not going to say that isn't something that I wouldn't do. I've just never done it. And if it works, you know, as long as like the patient isn't traumatized by it, I mean, it's okay to do, I guess. I mean, but that's not something that I've ever thought of doing, or I've not seen in my office.
Perfect. Well, I think we got through all of the questions. So thank you, everyone. I'll do one final call for questions. We've still got some time, but I'll go through my closing spiel. If one comes in, I'll answer it. Just a reminder, if anyone wants CE icon is in the control panel. Click that, fill out the short survey.
Well, I just want to say I'm so thankful to Henry Schein for allowing me to speak to all of you tonight. I'm really thankful. I'm humbled by it. And I want to thank everybody at Henry Schein Dental Education for offering me this webinar to do. So thank you.
Absolutely. And of course, a big thank you to you as well, Fran, for all of the insights, information, expertise, and everyone who attended. I mean, thank you for the questions. That's what this series is all about, is, you know, bringing new or even basic issues like pediatric care to light and kind of exploring all avenues on how to treat patients. There will be.
If anybody wants to contact me, I mean, you can. My email is fran.parathyras, my last name, at henryschein.com. And I'd be more than happy to connect with any of you on LinkedIn, Facebook. Please don't ever hesitate. If you have any questions at all, I'd love to hear from you. Thank you so much.
Excellent. We did record tonight's webinar, so we'll shoot that out to you via email sometime in the next week. As well, in that email, we will send an invite for our next Breaking Down Barriers to Care webinar, which is happening in June, and that's on the treatment of HIV. Thank you, everyone. Thank you, Fran. Have a great night.
Have a great night. Thank you.